science plays a vital role for economic development and societal well-being. Understanding this, the Academy of Sciences Malaysia was established with a mission to be Malaysia's thought leader in all areas of science, technology, and innovation. To realize its mission, ASM harnesses the nation's top scientific minds to chart the STI direction and facilitates the implementation of an innovation-led economy for the country. ASM's commitment lies firmly in fostering a culture of excellence in STI in Malaysia. ASM does this by providing independent, credible, relevant and timely STI input of national and international importance to the country. Our network of expertise comprises Malaysian scientists, engineers, and technologists who specialize in various disciplines. The Academy assists in upgrading the nation's technological capabilities in the industrial sectors by producing high-quality publications such as peer-reviewed journals, monographs, and books. In addition, ASM also provides input on current and future technology trends to be considered and taken up by the government in driving the nation's economy forward. To provide Malaysian scientists with the best opportunities and exposure, ASM actively extends its international networks and collaborations. It currently has a range of multilateral engagements with renowned scientific institutions worldwide. The Academy also champions the need to grow the right talent in STI by cultivating interests in science, technology, engineering, and mathematics to the younger generation. In short, the Academy's ethos is proudly defined as Think Science, Celebrate Technology, Inspire Innovation. science plays a vital role for economic development and societal well-being. Understanding this, the Academy of Sciences Malaysia was established with a mission to be Malaysia's thought leader in all areas of science, technology, and innovation. To realize its mission, ASM harnesses the nation's top scientific minds to chart the STI direction and facilitates the implementation of an innovation-led economy for the country. ASM's commitment lies firmly in fostering a culture of excellence in STI in Malaysia. ASM does this by providing independent, credible, relevant and timely STI input of national and international importance to the country. Our network of expertise comprises Malaysian scientists, engineers, and technologists who specialize in various disciplines. The Academy assists in upgrading the nation's technological capabilities in the industrial sectors by producing high-quality publications such as peer-reviewed journals, monographs, and books. In addition, ASM also provides input on current and future technology trends to be considered and taken up by the government in driving the nation's economy forward. To provide Malaysian scientists with the best opportunities and exposure, ASM actively extends its international networks and collaborations. It currently has a range of multilateral engagements with renowned scientific institutions worldwide. The Academy also champions the need to grow the right talent in STI by cultivating interests in science, technology, engineering, and mathematics to the younger generation. In short, the Academy's ethos is proudly defined as Think Science, Celebrate Technology, Inspire Innovation.
Ladies and gentlemen, let me begin by introducing myself. I'm very honored and privileged to chair this panel discussion on the topic of digital innovations for public health in the tropics. My background, I have been for some time an academic. Then I left to run a research institute, and that's more than 10 years ago. Since then, I've been a freelancer doing my own work, I guess, in the scientific field. My special interest right now is actually innovation, especially in the digital space. So that's where I am. Now, we have a very good session, I believe, because the four speakers that are due to speak are very specialized in their respective fields. So let me just spend a few minutes to explain the context of this discussion, which I believe is very timely and of course going to be very profitable. What the COVID pandemic has done is actually to accelerate many things. One of the things it has done is to accelerate the consciousness and awareness of the importance of public health. So COVID pandemic, I think, created a masterclass for all of us on how to deal with a pandemic on a global scale. It has become a global issue. It's not ended yet. It's still playing out around the world. But the issues revolve around roles and responsibilities. For example, the role of the state and the role of national actors, the role of the international and multilateral agencies, and the role of the private sector, and the role of the community and NGOs. So all these roles have been the subject of, I would say, dynamic change over the last 2 years. We have seen the challenges arising. Many of them remain unresolved, but some have been dealt with quite well by the global community with some sense of, I would say, responsibility and, of course, discipline. For example, we have actually managed to reduce the transmission through many activities such as testing, tracing, communicating. Prevention and treatment are already in play in many countries. Medical supplies, the supply chains, the masks, PPEs, drugs, respirators, all these things have been dealt with to some extent. And of course, right now, vaccination is a big issue. In countries like Malaysia, of course, we have been doing quite well because I see the numbers of infection dropping in the last few days. But the world over, of course, the infections remain high. The digital innovations have become, I would say, the technology of the time, because the rapid response that has been produced came about from the use, I would say, the good use of digital innovations. And the community has used many interesting models. I would like to mention a few. For example, open governance models were applied. There were flexible, adaptive regulatory mechanisms. There was very easy access to information that was shared throughout the community. Knowledge, AI, data analytics were applied. And of course, the post-pandemic world can expect to see more of this happening. However, all these things were done, I would say, in a very open, fluid style. What we may want to discuss right now is actually how to put more systematic actions in place so that we could see measurable results, not just within a few communities, but across the world. Now, I think we have heard from various speakers. I viewed some yesterday talking about the tropics. The tropics are a belt of countries around the equator with certain unique features. We are not the richest countries in the world, yet we have high growth, a young population, and of course, rich biodiversity. And of course, we may be a source of good as well as a source of some of the bad results of poor management. One of which I believe the COVID infection itself is an example. The fact that we did not manage to control the natural environment as well as we could have. And because of that, we have created all these potential infections that could devastate the entire human community. So with that few words, I think we are going to see both the good as well as not so good side, what the world community has been doing. And we want to start with the first speaker, who is going to be Dr. Anurag Agrawal. Quick introduction is from the Boston Consulting Group, based here in Kuala Lumpur. He was trained as a medical, doctor. Then he moved into management, and he's had many years of experience, especially in digital innovations. So let us welcome Dr. Anurag, please. The floor is yours.
Thank you so much, Dato. So in the 5 to 7 minutes that I have, I will speak to you about how we have seen digital shaping healthcare and what are some of the key challenges and pitfalls that one should be aware of as organizations use digital to shape their agendas. If I could take you to the next slide, there are four overarching themes that we see today that is having a fundamental impact on healthcare. And you would relate to some or many of these. The first is rising consumerism in healthcare. Patients are increasingly moving from being patients to consumers. They have access to data. They are seeking for best quality care at fingertips, in their homes. The second is healthcare systems are increasingly focusing on outcomes and on value, a trend which we call value-based healthcare, which means healthcare systems today want to deliver the best possible quality at the least possible price. And hence, all backend systems are gearing to ensure that this happens. The third is, and you would see this, both in emerging and developed markets, is that the healthcare ecosystem is getting reshaped. So new entrants are entering the market. You have startups delivering healthcare, telemedicine, delivering pharmacy products to your home, ensuring that consultations happen, even delivering home-based care. So the healthcare market is getting disrupted. And a fundamental driver to many of these trends is what we have come together here to speak about, which is the digital and tech trend, which is an important enabler across AI, AR, VR, and even simple elements like EMR and EHR, which are driving this fundamental shift and transition in healthcare. If I could take you to the next slide.
Next slide. Okay. Yeah.
So we surveyed about 1,000 odd organizations across industries to see how did healthcare stack up in terms of digital maturity and ability to disrupt the ecosystem digitally versus many other industries. It clearly emerges that healthcare is somewhat of a laggard in terms of adopting digital and leveraging digital for innovation. Especially if you look at the right-hand side of the slide, across the four big sectors in healthcare, biopharma, medtech, providers, and payers, biopharma and then providers, providers being the key public health facet of healthcare, are particular laggards in terms of using and adopting digital across having enablers, having mechanisms to digitize their core, having mechanisms to drive digital growth. Yeah. If I could take you to the next slide. We also tried to understand, and this is another survey that we did before the pandemic, to understand where are organizations investing. And even before the pandemic, I would point out to you that digital was top of the agenda for organizations and for investors. So digital capability was indeed a priority. You can see on the left-hand side that across different opportunities for investment, especially healthcare organizations, 50% of them were focusing on investing in digital capabilities. However, when we ran a similar survey on the right-hand side, results that you can see is that about 80% of healthcare organizations were, as a result of pandemic, trying to accelerate digital transformation. So having realized that digital is a new way of delivering care, about 85% of organizations hence wanted to accelerate digital transformation and put it as top of the house agenda for them. If I could take you to the next slide, while the intent is there, it is not the easiest task to do. Okay, out of about 800 odd organizations that we looked at, only 25% of these organizations were able to navigate a digital transformation successfully. So yes, 85% of them were interested in doing digital and putting digital at the top of the house, but only 25% of those 85% were able to deliver a transformation successfully. And there were organizations which did well. So we studied what is driving the success of those organizations which have been able to successfully use digital. And a few themes emerged. None of this is rocket science. It is something that you would perhaps do when you focus on any other part of the organization, but these are important to keep in mind. The first was having a holistic strategy with clearly articulated goals for digital. So not doing digital for the sake of doing digital and because everybody's talking about it, but having a clear plan, a clear vision, a clear goal of doing digital. The second is once you have set that up, putting a robust monitoring mechanism quarter on quarter, year on year, with milestones and KPIs, which can then track progress towards this transformation. Like always, top of the house buy-in on driving this, which is CEO and leadership commitment, head of organizations, head of institutions, but very importantly, digital changes the way that people work. So it cannot be a only top of the house agenda. So securing middle managerial buy-in, people who do day in, day out work, again, extremely important. Learning to fail fast is the fourth one. You cannot keep on doing digital and realize that end of 6 months you have done something wrong. These iterations need to happen in a matter of 2 weeks, in a matter of 3 weeks. So, doing that. Having new talent infused to run this digital agenda. This is not something that can be done by talent that has historically not been accustomed to digital interventions, to digital technologies. So either getting new talent to drive this or building capabilities and in-house upskilling so that these agendas can be driven in an appropriate manner. And finally, investing in technology, because to do all this, you would indeed need to have the right flexible and modular technology and data platforms to drive these efforts. So in a nutshell, to summarize, healthcare is getting disrupted. Healthcare organizations are behind the curve in terms of adoption of digital. Pandemic has put the digital agenda front and center for healthcare organizations. Everybody is trying to do it and do it well, but only a minority of these organizations are able to do it well. And that is driven by a set of success factors that one needs to keep in mind. That's what I had for the initial preamble. Happy to discuss and take questions later on in the Q&A. Thank you so much.
Thank you, Anurag. For the participants, let me just say that you are welcome to post the questions starting from now. And the secretariat or my assistants will help us to consolidate the questions, and then I'll try to post them for you later. If you wish to post a question yourself, you're also welcome. You can raise your hand, of course. All right, let me introduce the next speaker, who is going to be Dr. Helmi Zakaria. He is actually a Malaysian. He also is a medical doctor, trained in medicine, but decided to go into public health. He has a master's degree in that field. And he has been working very closely with parties in Malaysia and in the region on using IT for the COVID crisis. So let's hear from Dr. Helmi. The floor is yours.
Thank you very much, Prof. Well, Dr. Helmi Zakaria, everyone can just call me Helmi. I'm a bit awkward with the title of doctor nowadays, because rightly so, my background is in basically it's medicine and in public health, but I think starting from 2012 onwards, I specialize more in terms of global health policy. So I had a short stint. In WHO, and at that point of time, I was championing the agenda of dengue. And rightly, you said, because in the tropics country and subtropical country like us, we usually are not that rich that we can come up with our own solution. But likewise, we are not that, for the lack of better word, poor enough to get an international aid. And therefore, when I was there, I was trying to champion the agenda of dengue to get more investment into tools, diagnostic, etc. But I think I became a little bit disillusioned. I think by the end of 2017, I thought like, okay, aside from global health policy, there's probably something else that can be ventured into, and that's when I leave, and I basically I invent my own startup, which is called as AMI, Artificial Intelligence for Medical Epidemiology. In specific, what we are doing is like we're just trying to make public health more sexy lah, for the lack of better word. So we apply machine learning, we apply artificial intelligence, because for the longest of time, I think likewise, just like dengue, public health in general have always faced this underinvestment, right? Because like our previous panelists were saying, there's an increasing trend of consumerism around healthcare. But when it comes to public health, it's very hard to translate those public health versus individual healthcare. And I think I was I think I was still in Brazil at that point of time when the Selangor state government actually called me back to come up and to help with the digital to spearhead basically the digital solution to guide the Selangor state government response towards COVID-19. I think maybe we'll talk a little bit more about this along the conversation. Right, that's all. Thank you.
Thank you, Dr. Helmi. That's a very quick one. So we can expect you to say more when we start discussing the issues involved.
For sure.
All right. I still do not see Dr. Rose, who's supposed to be the third speaker. So I would like to move to the next one, and that's MS Lakshmi Balachandra. Lakshmi represents the CHAI, which stands for the Clinton Health Access Initiative. Is that correct? I hope so. She has been working on many countries. She is trained as an engineer and went on to do a master's degree in public administration from Columbia University. So she has experience in this region, and I hope she can share what she has been doing in terms of managing infectious diseases in the tropics. Lakshmi, the floor is yours.
Thank you so much for the introduction. My apologies if I'm a little bit slow. It's a bit early in the morning here, but I hope I'm clear and contribute well to the discussion. I wanted to focus the next 5 or 7 minutes on how governments in the tropics are using digital health and innovations, specifically on disease elimination. We can go to the next slide. So at the Clinton Health Access Initiative, or CHAI, we work specifically with government programs, mostly or primarily in the tropics in sub-Saharan Africa, Southeast Asia, South Asia, and Central America. And a lot of what our work is around reducing disease morbidity and mortality and eliminating disease transmission. We focus on disease elimination for malaria, and for neglected tropical diseases, for hepatitis, and a few other infectious diseases. So like I said, I wanted to spend a little bit of time on just how do we use digital solutions and digital innovations within this space, and particularly how do governments drive some of this digital transformation. You can click, I think there's an animation on this slide, you can click a little bit. So governments typically focus on case management and preventive measures to drive lower disease morbidity and mortality, and to eliminate disease elimination. The technical approach that's on this slide is usually taken from WHO guidance for these diseases, and somewhat follows similar themes across diseases. They're focusing on making sure that patients receive high quality diagnosis and treatment across health facilities, community health workers, as well as the private sector. And they're making sure particularly that at-risk communities are protected by vector control, which might be bed nets or insecticide spraying, chemo prevention, and other context appropriate tools. If you can click once more. What's foundational to driving better, more effective case management and preventive measures is a number of things, particularly around data. The intention increasingly is to make sure that strategic planning and planning for making sure that routine health services are delivered well is driven by data. So a lot of governments focus on strengthening information systems, improving the routine use and analysis of data, and facilitating data-driven strategic planning. More often than not, that's where digital innovations and digital health fit in making sure that we're collecting good data, that we are reviewing, integrating data in an effective way, and reviewing the data for decision making. So I just wanted to present sort of an overarching technical approach that comes, like I said, from across a number of countries and a number of different disease areas. In the next few slides, I'll just give a few examples of how governments have used digital innovations just to spark conversation. This isn't a whole representation of what all governments are doing across the board, but just where digital can be effective and where maybe it might not be appropriate. So the first one is a case study in Thailand. Focus investigations are essentially follow-up investigations, particularly when you're looking at disease elimination, where the number of cases of a disease are very, very low, and you want to sort of target interventions at completely eliminating a disease. So countries will often focus on a specific village or clusters of villages to see where are the areas of transmission and how can we reduce transmission in those areas. So up to 2018, Thailand was conducting these investigations and response, like net distributions or studying entomology, so mosquitoes on paper. And large amounts of data were being collected in this process, but we're not being informing their elimination strategy. If you can click on. And one more, yeah. You can click through the slide, yeah. Great. So they, in the last 2 to 3 years, they have started using, digitizing this process, essentially. They use a web-based application to review historical data and to plan how they want to conduct these investigations. They, I believe, every 6 months conduct investigations in every single area of high transmission. They then have a mobile application to collect data that they see during this investigation process. So where are the cases coming up for malaria, and how are they responding to this? Are they distributing beds and nets in those households? Are they doing additional tests for malaria to detect if anyone else has it? And then they review this data on dashboards that are presented towards the right. Overall, it's been a very effective process. They've begun using data much more frequently on a weekly or monthly basis in order to start planning more strategically how they should respond to areas of high transmission. Next slide. In Mozambique, you can click through once more. My apologies for the animations. I thought I might be controlling the slides. In Mozambique, in 2016, the government conducted a national surveillance assessment and identified a few critical challenges. They saw multiple sources of data that were relevant to malaria. So this includes stock data on malaria tests and treatment. This includes data on cases, on entomology, on distribution of bed nets, on insecticide spraying, etc., lying in different data sources. Oftentimes these were Excel sheets or access-based platforms, or sometimes web-based platforms. And they were different for different provinces in the country as well. So it was very difficult to look at the data altogether and understand what's happening with malaria within the country. And there were no automated outputs. So someone was always integrating and analyzing the data together. We can click on. What they've worked on now is a malaria data repository. And again, this is at this point WHO guidance as well, is to create malaria data repositories that essentially bring together any data that's related to malaria into a single data repository, and then review that data together. So what Mozambique has done is integrated their routine monthly public health reporting system, their supply chain system. They've imported historical data from population and census data, survey data, entomology data. And instead of using Excel files to track all of this, they're essentially doing data entry into a web-based platform. They're still in the process of integrating additional data sources and rolling this out in additional provinces. But again, this has made the process much simpler to review data and to plan what needs to happen next. I'll just do one more example, which is the next slide. In Honduras, again, they were In 2014, a surveillance assessment revealed that they had limited case-based data, which is very important typically for disease elimination. So understanding on a case-by-case basis for every single case, what were the drivers of the case coming up, etc. And they had information offices only at regional levels, which means their review and response to data was fairly limited. And low capacity to work on the information system itself. You can click through. So in the last few years, similar to Thailand, but specifically to case data and case disease surveillance, they've essentially set up a mobile-based case notification system, as well as a web-based platform to review all of the information that's coming in. So this information, essentially, as soon as a malaria case comes up, they enter a little bit information about the case itself, and then they have a follow-up process for the next couple of weeks to follow up on the case and make sure that it is responded to as well. So I'll stop there, but essentially, like I said, just wanted to give a few examples as food for thought, and thinking about how the public sector plays an important role in healthcare and particularly disease elimination in the tropics. Thank you.
Thank you. I still do not see Rose coming in. Is she coming in? Anyone can tell me? Rose is from calling in from Uganda, and apparently for the information of participants, she's having difficulty to log in. Can we then proceed? I actually would like to do this. We can see that the first interventions by our panel speakers have actually been able. I see Rose material coming through. Is she speaking? Can somebody confirm? Rose is not signed in, or she's not signed in or not? She's signed in or not? Can somebody say? Aizat, can you tell me?
Yeah, Dr. Tengku, I think she has a problem with signing in into the WebEx.
Okay, it's okay.
Maybe we can proceed to the next session. Then when she joins later, then we can.
Yeah, apologies for that. Rose is still having difficulty to log in. This is what I will do. I will pose a few questions for our panel members to respond. All members are welcome to put in their interventions, no problem, and we'll take it from there. Let me start with the first question, which I think is worth considering for the sake of all our participants. What do you think are the major trends in public health, and why are they emerging now? Would you like to say something about that? I don't want to start with digital transformation or digital innovation, but what are the trends that are happening? The COVID crisis is actually a crisis in infectious disease. There could be other health crises, such as, for example, lifestyle diseases, which are very common in this part of the world for many reasons. So it could be lifestyle. For example, obesity is a major issue in countries like Malaysia. I can tell you that it is a serious problem here. And of course, with obesity, you have diabetes, yes, heart disease, etc., etc. And of course, we have other trends such as the increasing age of the population, demographics. So we have actually two peaks, the young people as well as the old people. This is very interesting phenomenon. So demographics, another trend. Would you like to examine some of this, and let's see whether we can come up with some ideas of how to move forward as far as digital innovation is concerned? Anurag, anything from you?
Yeah, so you absolutely pointed out the right challenges, Dato. I think if we look at ASEAN as a region, and I think perhaps would be true for broader tropics as well, a few demographic trends are putting additional burden on public healthcare systems. Yeah? The first is increasing population. Just globally, this is the part of the world where population is increasing, one. Second, aging of population. many countries are going to be progressively aging and very rapidly aging. Okay. And the third, like you described, is greater prevalence of non-communicable diseases, hypertension, diabetes, cancer, so on and so forth, which are fundamentally diseases which require care which is given over a longer duration and use greater healthcare resources versus, for example, an episode of malaria or dengue. So all of these challenges are putting and are expected to put an extremely high burden of disease on the healthcare systems. And that is not just true for the more emerging markets in the tropics, but even the developed markets in tropics. For example, Singapore, where in the past 7 to 8 years, the percentage of GDP, which is spent on healthcare, has increased from 3.3% in 2012 to 4.5% in 8 years. So this is a major challenge for public healthcare systems. And hence, what are healthcare systems doing to address this challenge? Yeah, a few things. One is they are pivoting, and which I alluded a little bit in my conversation, to what is called value-based healthcare, which is organizations, public health organizations are looking at healthcare which is going beyond quality only. So they are looking at healthcare as a numerator of quality and a denominator of cost, which means we don't want to put in the most expensive stent for a coronary angioplasty, but we want to put in a stent which has got good outcomes, but at a very good price also. So a value-based healthcare dimension is emerging as a big theme. The other important thing that is emerging is what is called integrated care models, which means, look, today patients and a large proportion of patients end up in tertiary hospitals, complex care facilities for simple illnesses. Okay, for simple cold and cough, they would end up visiting a tertiary care hospital. Public health systems have realized that that's not the best way to treat a patient when you can get the same cough and cold patient to be appropriately examined and treated at a peripheral facility. So these integrated care models are emerging where right siting of care, which means delivering the right care at the right place, which means I don't want to keep a hip surgery patient, hip arthroplasty, hip joint replacement patient into a tertiary hospital for 10 days. I want to keep him or her there for 3 days, and then for step down care, move them to a community care hospital where they can get same care but at a cheaper price. So these integrated care models are emerging. Okay, and the third thing, especially where healthcare systems are capitated, where healthcare systems are today fee for service, yeah, where what essentially means is if a patient goes to a hospital, he gets some care taken, and the hospital then gets reimbursed from the government exchequer at a certain price per procedure. That model is changing. Organizations and governments are moving towards a capitated model, which means, look, there is a health cluster which caters to a population of 1 million people. As government, I will give you a certain amount, okay, $1 billion, $2 billion, and you manage the health of the population within that amount, okay, and do whatever is required instead of a fee-for-service model. So these capitation models are emerging in public healthcare increasingly. Again, the entire focus is, to your point earlier, how do we manage this increasing demand of healthcare services, okay, by the fundamental drivers with the limited resources that we have? So that is the big theme and the big challenge that I'm witnessing in public healthcare.
Thank you, Anurag. Can we go to Lakshmi? Do you have a comment on this? Your view of the dominant trends?
I don't have a lot to add to the trends itself. I think both you as well as Anurag sort of pointed out what I was thinking about in terms of demographic trends and trends within diseases within the tropics, especially. What I can add to maybe what Anurag mentioned is what are the trends in how governments are responding to this as well? So not just private healthcare organizations, but governments as well. I think integration, as he mentioned, is a big theme, not just integration between different levels and types of healthcare settings, but also integration across how we respond to diseases or just provide healthcare to patients as well. I think over the last 20, 25 years, there's been huge sort of vertical efforts to look at big disease burdens like HIV/AIDS or malaria or TB or routine immunization, etc. And now there's more of an effort to think long term and think about how do we invest in healthcare as a whole and health systems as a whole, and not just what do we do with patients who have HIV, what do we do with patients who have malaria, etc. So there's a lot of, I think, focus on infrastructure, improving health workforce, improving public healthcare in general, and moving towards universal health coverage, which is very good to see. So I think that's one thing that stands out to me as a trend within the public sector healthcare provision within the tropics.
We still don't have Rose, but I think Helmi
I
also.
think I see. I saw Rose.
Is Rose here?
Dr. Rose is already in that one.
Is in. Okay. Why don't we give Rose a chance to make a presentation? Rose, are you here?
Yes, I am.
All right. Thank you. Let me just quickly introduce you. Dr. Rose Nakasi is from Uganda. She is I would say a computer scientist specializing in artificial intelligence and located at the Makerere AI Lab, and also a lecturer in the Busi Tema University in Uganda. So, Rose, the floor is yours.
Thank you very much for that kind introduction. I'll drill to the presentation right away. And this is part of the work that we've been doing at the Makerere Artificial Intelligence Lab in Uganda. And it's basically about automating the way malaria is diagnosed, especially in Africa. Next slide, please. Yeah, so why healthcare, and the motivation behind this work was basically to improve the well-being and reduce suffering and extend health care to especially our people, and particularly in the domain of diagnosis. So if we can be able to diagnose the disease at whichever stage it is, then we can be able to give, specialized care, and then reduce cases of misdiagnosis, and then reduce on the burden of the disease. Next slide, please. So malaria is a tropical disease that is spread by a mosquito bite. And especially in the sub-Saharan Africa, we have seen that malaria is one of the leading causes of death. Actually, it ranks around the 10th in the top 10 diseases. When it comes down in Uganda, where I come from, it has accounted for over 27% of the lives of Ugandans. And according to the WHO report, we see that around 229 million cases have been reported globally as having cases of malaria in around 92 countries. So the burden here we see is that in most of the highly endemic areas, we see so many patients waiting in big numbers, waiting for a correct diagnosis to be given. But then, next slide, please. But then in most of these endemic settings, we see that there is a lack of enough trained microscopists or lab technicians to be able to give a correct diagnosis of the disease. A study that was carried out in Ghana reported that there were 1.72 microscopes per 100,000 population. So you clearly see that we only had 0.85 trained lab technicians for that 100 population. So that then means that we have actually, in most of the public health centers, we have more microscopes than the trained microscopists to be able to give a gold standard mechanism for diagnosis of the disease, yet we have so many patients that come with malaria. Next slide, please. Based on the gold standard mechanism for the diagnosis of the disease, we see that it has some limitations, especially the standard operating procedures, which do not allow these microscopists to be able to view more than 20 to 30 slides a day. The procedure in itself, we see, is also eye straining, where a lab technician has to strain the eye to look out for these pathogens in the blood sample, and also the variations that come with their expert judgment on what they see under the microscope. Next slide, please. So our concept here is to leverage on the current technologies, especially the mobile telephones, which are, increasingly coming on the markets even in sub-Saharan Africa, where the disease is highly endemic. We want to leverage on also the microscopy method, which is the gold standard, and then leverage on the current artificial intelligence powered models to be able to assist in the way the pathogens can be detected. So our model is to be able to align a 3D printer onto the eyepiece of the microscope, then use the smartphone to be able to capture the image under the microscope, but also be able to detect the parasites under the microscope. So in this way, we are reducing on the amount of work that the lab technician is going to use while looking out for these pathogens in the blood samples, reducing on the strainers mechanism of the microscope, and also improving the way malaria is diagnosed. And in the long run, we believe that such an innovation will be able to improve public health in the tropics. Next slide, please. So those are the kind of images that are captured on the smartphone. And what you see and as red there is the pathogen that the model is going to learn and then be able to offer a diagnosis. So at the end of the day, in the last slide, please, what we came up with is that what you see in red are the parasites that were detected by the artificial intelligence models. And then on the white, those were the validations which were made by the microscopists. We ran this for some more microscopic challenges like the tuberculosis, and clearly the artificial intelligence has shown capability in being able to, in performing the detection of such diseases. We believe that this kind of work is going to be able to improve the way the microscopists work, and as such increase on the throughput of the patients that come in large numbers waiting for a correct diagnosis to be given. Thank you very much. That's just brief of part of the work that we're doing. Thank you.
Thank you, Rose. Good example of how AI can be used to detect objects in pictures, in images. Earlier, I was asking the panel members to respond to a couple of questions. One question: what are the dominant trends in public health, and why have they become dominant or prominent? And I pick up a number of interesting factors that I thought was pursuing. Anurag, I think, mentioned about the high cost of medical care. And I would say one trend is actually the changing business model. Am I correct? This is where I think all countries are going to face challenges in delivering affordable health services to the population, to all citizens. There are other, of course, trends, but we're building towards answering the question, why should we apply digital innovations? Digital innovations, as you just explained, Rose, may be used actually to create more effective solutions as well as to reduce the cost of solutions. So this is why I think we are learning from the COVID crisis, which was actually a crisis in communicable diseases. But we also have non-communicable diseases in the tropics, and we covered some of them. I try to move to the next question, just to finish off this part. If these are the trends and these are the possibilities of moving forward, what do we think are our challenges in responding? Especially, how do we produce proactive responses? Do you want to, Rose, do you want to come in at this stage, or you want to let the others respond first?
Yes, thank you. On the issue of what are the challenges of the bottlenecks, especially in using digital technologies. One, we come from a particular kind of background where we're dealing with multidisciplinary fields. You have the technical people on one end, and then you have the medical practitioners on the other end. We have been trained differently, like the medical people have their own procedures and how they provide healthcare. Then we come in with artificial intelligence, for example, to be able to augment what they do. So this kind of multiplicity requires a big talk whereby you're going to prove to the medical personnel that, you know, these kind of technologies are able to do some bit of work or to augment the kind of work that you do. Well, this may not usually go well with the other field, especially the medical people who have their own protocols and procedures. So there is need indeed to have a dialogue between the technical people on one end and then the medical people on the other end, and being able to, you know, reach a consensus on the way things work, and then with that we can be able to move forward. Then the other thing is about some of the environments under which digital technologies are going to be deployed. So I may come from like a setting where the government procedure and transferring them to another field, especially one of the sensitive sectors like health, can take sometimes longer, and so that creates also a bottleneck. So if you have governments coming on board and being supportive, putting across policies and regulatory decisions that are able to support the digital innovations, then that can also go a long way in solving some of these gaps.
No doubt, the role of the government is very, very important. We'll take that up later. But for now, can I invite Lakshmi or Anurag to respond? What are the, you know, the responses that we could think of to meet these challenges? Anyone?
Yeah.
If I may add juga, I mean, if you don't mind me, if you didn't mind me hijacking the
I mean, you're
conversation.
back. Okay.
Yeah. So when you're talking about, I mean, earlier one of our panel did mention that one of our concern at the moment is the increasing cost of healthcare, the increasing cost of treatment, right?
Yes.
So one of the trend that we basically observe and monitor is basically there is this. I personally feel dealing in innovation and technology in health, I feel that mainstream innovation and investment usually cater too much on the downstream. You know, we invest so much in diagnostic service delivery, personalized treatment, but if we really want to tackle health issue at its roots, then I think some of those innovation need to move a little bit more upstream, basically in terms of population preventive health analytics, right? And I think this will segue quite nicely to our next topic when we talk about how do we use multitude and various non-health data points to actually give us a visualization where the disease is going to take place next in the population. And therefore, you can cater or curate a policy or a population level intervention more precisely and more targeted, right? Because I'm a big proponent of social determinant of health because I'm from the background of public health. And I realized there was this study that said it come up that healthcare service only account to about 20% of impact on a person's health status, right? So I think a little bit more focus on population preventive health analytics. I think that's what is needed at the moment. It has its challenge though. Like so, for example, my startup, Amy, if you don't mind, I will share a little bit of screen. Right. So I'll share a bit on my screen just to give an idea of the challenge that I face. Right. So can everyone see my screen?
Not yet.
Not yet. All right. What about
Yeah,
now?
we have it. Yes, go on.
Okay. So I deal a lot in population health analytics, right? And when it comes to population health analytics, usually obviously the disease of concern that we tackle would be communicable disease, infectious disease like dengue and Zika virus. But likewise, interestingly, I want to highlight that we also deal in terms of, for example, antibiotic resistance, which we can tie to basically number of sales of antibiotic, either it is prescribed or otherwise from pharmacy across the country. And therefore, we can see how the trend of resistance start to emerge. And it is not, I would say that the trend is not similar nationwide, and it need a bit more granular understanding and granular insight from one location to the other. Likewise, for the state of Selangor, for example, we run this project together with Perkeso, where we found that the features, we call it features, or the factors that determine the likelihood of somebody to eventually diagnose with one of the more popular NCD in Malaysia, and likewise, once they are diagnosed as diabetes stage 1, how fast they progress to stage 2 and stage 3 is quite predetermined based on their postcode. It's quite determined based on the distribution of fast food joint, of available mama, we call it here. What are the human development index per state, and this kind of factor. Usually not neither biological or behavioral. The challenge that I have, as a startup that venture into this, I would say, discipline of population health, is the difficulties to basically get investment or backing out of it. Because like our earlier panel was saying, when we talk about individual healthcare, it's easy. You have a health problem, an individual health problem, usually you can get a treatment for yourself, or you can do some preventive measure for yourself. But when we talk about population health and preventive strategy, usually get a little less investment and emphasis being given on that,
Yeah.
despite the evidence that.
So are you done, Helmi? Helmi, are you still continuing? Okay. I think I
Yes,
picked
yes,
up
sorry.
from Helmi is
No,
actually
no.
how I can help us to produce a predictive models, right? Basically, that's what it is. I would like to move now, unless we, Anurag.
Their bar on evidence is high. And hence, getting them to buy into digital technologies and earning their trust and earning their faith is a long, drawn out journey. So, whenever we have adopted digital solutions in public or private setups, what has worked well is involving clinicians early on. Okay, getting their buy in early on during the design stage itself versus developing a solution, testing it, piloting it without their support, and then coming to them with a final product. That is a recipe for failure. So engage the clinicians early if you want to make it a success.
Thank you. Lakshmi? Not now, later?
Nothing major. We can keep moving. Yeah.
Okay. Let me address 3 questions that have come up on the screen, by the way. One from Professor Mazlan, my colleague, organizer of this conference, by the way. Another from Nurul Hasana. And of course, the last one is from Aminatul Saadia. They're all ladies, by the way, very powerful group here, ladies. I will summarize them. Basically, they are talking about the human side of things and on the ground, the reality on the ground. From Mazlan, she's talking about how do we actually deal with digital solutions when there's huge digital divide. This is an issue that's been going on for many, many years. It still exists. From Nurul Hasanah, she's asking about the data that Lakshmi produced in Thailand and Mozambique, for example. But I would like to expand the question to this. Actually, when you want to use AI, the beginning is always data. People have asked me before, oh, can I apply AI? So I said, where's your data? They said, none. There's no AI for you. And the data must be clean, must be sanitized, must be tagged. Yeah, you have to tag the data. A lot of work goes on. So it's just not mere raw data. It's actually smart data. The last question is from Amirul Sadia. She is talking about the current trend in digital health is to focus on the cloud-based health data, she calls it, and mobile apps for the population. What about digital apps for health professionals? She's asking. I call these gaps on the ground and the real gaps that exist. So I'm trying to paraphrase the question to see that how do we actually bridge these gaps? Any one of you can respond in any sequence, in any, you can handle all three or only one of the issues. I hope you got the questions. Who wants to start? Lakshmi, you want to start?
Sure, happy to. I can start with the digital divide and then go on to the others. I think the digital divide is a very good point that's brought up, and it's challenging, especially within the tropics, where in some areas, in some countries, you have incredibly strong infrastructure, and in others, it's much more challenging. And that's where I think it comes down to a few things, at least in our work, where we're working with governments and within the public sector healthcare. One is investments in infrastructure in parallel with digital solutions and innovation. So not just going in with a specific platform or app or something that we think will solve all of the issues, but also looking at the infrastructure and making investments there, whether it's improving connectivity, whether it's improving power, and other aspects. Oftentimes, these are applications and systems by governments that are introduced within health facilities, hospitals, or district health offices, etc. So not necessarily targeted at patients and the general population. So this is less about providing them with smartphones or phones or tablets, etc., but more so making sure that the infrastructure exists within the healthcare system to be able to access the technology. The other is making sure you're designing technologies that are fit for the context that you're working in. Oftentimes there's an attraction to try and introduce sophisticated technologies that can do wonderful things. Infrastructure is one of the reasons that it might not work. I think something that Anurag and others mentioned earlier as well is that you need to make sure there's buy-in from users before you start introducing something that will change their day-to-day life completely. But certainly infrastructure is one of the things to consider as well, whether doctors or nurses or health workers have the access, the digital literacy, the infrastructure in order to be able to use that technology. So I think there's various ways to think about it, but completely agree that it's a big challenge and consideration in how we work on digital and where it is appropriate.
Okay. Next, Anurag or Helmi or Rose.
Yeah. If I may add to the second point that Lakshmi mentioned around designing digital solutions that are fit for the context. I think that's an extremely important point because, look, infrastructure interventions and infrastructure investment will take its own time, right? I mean, look at Malaysia, for example. Rollout of Jendela has taken the time that it has, right? But it doesn't mean the population should wait for those solutions to come up. And this is where innovation by social entrepreneurs and we call it frugal digital innovation comes into play.
Mm.
I mean, there are examples that abound today in resource-constrained countries where they're using the they're using recordings of voice to diagnose thyroid diseases. Yeah, it's a screening mechanism, but it is still a mechanism. It's better than having nothing in place. Yeah, there are startups like EasyRx, which are able to screen for anemia and blood disorders using frugal innovation. Yeah, the startups like Cola Life, which are piggybacking on one of the most comprehensive supply chain of, which is Coca-Cola, to supply antidiarrheal kits to the most remote and far-fetched areas. So it's about how you scale up these solutions, in the fit for context paradigm that Lakshmi described. Because infrastructure investments will take its own time. Humanity has to find a way to overcome them in the near time period.
Thank you. I like the term frugal digital innovation. Let's remember that term. I want to take that up later in another context. Anyone? Helmi or Rose?
I'll come on
I
the
thought when
issue
we
of
talk about
smart data or data, especially where I'm coming from the domain of artificial intelligence, where anything called a model consumes a lot of data. So when you're talking about medical data set, especially from the context where I come from, sometimes it's really very hard to get a lot of data, especially on some of the emerging diseases. So for example, COVID, which has just come, and you want to train an artificial intelligence model on such kind of data set, it will take a bit of time to get it. But also the environments under which this data is accessible is also another issue to look at. For example, what are the regulations around the data sets that you collect? Do you have permissions to be able to collect such data set? Do you have ethical approvals that come from the patients from whom you're going to get the samples, but also the medical, profession from which this data set is going to be extracted from? The other thing, especially the outcomes of the digital innovations that are going to be developed from such data sets, is we look at now the issues of representativeness in data. And I like the way when Lakshmi talked about developing digital solutions that are relevant to a certain context. So also the kind of data set that you're going to collect, usually some people develop models that are based on data sets, for example, from Europe, and you want the solution to be applied in Africa. So usually that is also, one kind of scenario that requires a critical concern when developing digital solutions in public health, depending on the context where these solutions are going to be deployed. So we need to collect a representative data, and I also like the way that you called it smart. It's not just about how much data you collect, but how representative it is from the kind of context that it's going to be applied in. That should also be given a critical concern. Then the other thing is about making these data sets. I heard you talking about making, cloud-based digital solutions, but then also the issue of ethical issues in the way this data set is handled also comes in. Do we have ethical infrastructure or ethical frameworks to be able to guide the way these solutions or the way data set, especially from the public health, is to be shared out, and is to be given a way to inform the kind of solutions that are going to come out of this kind of data set. The other thing is about having silos, especially from the given solutions that we work on. So for example, I'm in Uganda and I work on a given solution here. So if there is a framework that could be able to assess the different digital solutions or digital innovations that come from wherever, from different contexts, then that could also be able to work. So if I develop a malaria diagnostic tool in Uganda, where is the assessment framework to be able to know that, well, the kind of model that I've developed to diagnose malaria is actually going to work? So there should be frameworks that should be able to, to be able to assess the kind of digital innovations, not just in silos, but based on some standard operating procedures or standardized benchmarking solutions that are in place to be able to give confidences in the digital solutions that are being developed. Thank you.
Helmi, anything from you?
Yeah, I thought I want to combine 2 points. The first being development in terms of context, right? So I think rightly so, like what Anu was mentioning just now. I think some of my experience when dealing with COVID-19 that there was a lot of digital solution out there, but it doesn't seem like when it was designed coherently in terms of context. So I think what we managed to do is like when we come up with a digital solution, we first laid down the foundation of a design that the design should go alongside the health strategy, or at least in COVID-19 cases, it's basically the WHO global response strategy. So when we come up with a digital solution, it must at the very least cover all the 6 trusts or the 6 response key area for COVID-19, like, on in terms of how to find, how to deploy tests, community tested, targeted testing, how to trace people, and if people need to be isolated at home, whether you will be able to monitor them remotely, and when it comes in terms of support, like when the government lost the means to extend the aid and welfare to its citizens because of lockdown, whether this can then be done digitally, and in terms of vaccine, like if the digital barrier is there, what can be done to close it? And interestingly, first is context, right? But a lot of this digital solution then usually it will come up in a form of an app, for example. So if it designed in form of an app, it also means that it will require it will require um, it will require investment in a device. It will require in terms of constant connectivity and a mobile broadband. I actually come from a background where I believe that everyone can and should have access to digital facility, but it should not be tied to their ability of owning sophisticated device or their skill in operating one. Right. So I think tech, when it's being developed, it should be people centric. And this philosophy is not new. I think you mentioned during the pre-council, like it started from a pain point, like M-Pasa in Kenya. The pain point was like of access to banking and financial service. So to leapfrog those nifty solutions, they run a digital finance solution running on SMS. And that's what we try to do also in Selangor. So in Selangor, when people don't have the means to access all of this digital solution, it's usually because of the lack of device. So what we did then is like we transfer that capability we actually learn from the financial sector. If you still remember the ATM machine, I don't know whether people still use the ATM machine now, but if you think about it, right, last time what we have one ATM card, but we don't have access to time. But with our ATM card, we can go to any of the outer television. We can insert our card. They exactly know who they are, and then it means okay, these people now can access the financial service through the ATM. And that's basically what we did for in Malaysia, for Sri Lanka. All this functionality of an app. What we did is like we issue a card for people who are, for the lack of a better word, digitally gap or have poor digital health literacy, to issue a card for them, and all of this card basically tied to their personal identity in a form of QR. And when they need to access the healthcare service, what we did is we turn everyone, mobile phone of everyone around them, whether they're children, their grandchildren, or whatnot, as a means of access terminal. So people who don't have a digital, people who don't have access to sophisticated device or connectivity, they can then rely on in their nearest community member to help them to access the same digital tool, but leveraging on others software. And why we do this is because when after we run a community testing, for example, I like to show some statistics in Selangor, right? And then you will see, because the way how we deploy our testing and community testing, we focus more on the marginalized community. And as you can see, at least in Selangor, the one that is being picked up by the Selangor state government or by MOH are mostly people who are from the marginalized community. They are usually foreign workers, migrant workers. They don't have a proper home isolation. A lot of them don't have access to smartphone, and they have nobody to, as a home caregiver. So we then need to think, like what was mentioned just now, tech, but a frugal tech. How can we deliver this service by using the bare minimum equipment that is available back then?
Thank you, Helmi. We are actually running towards the end, so I want to pose a few key questions before we actually complete this discussion. Let me deal with the human side because that's what we're working towards. You can hear from a few speakers now. Anurag mentions, for example, the frugal approach, as well as, I would say, the high standards held by the medical professionals, doctors, before they accept any innovation. I want to move to the what Rose mentioned before, the responsible side, the ethical side. As we know, there's so much irresponsible and unethical innovation around, especially in the use of AI. AI can be used for good as well as for nefarious purposes, I would say. And it is happening right now. Can we respond to that? How do we actually manage AI for good rather than allow it to be abused by bad actors? Very open question. Anyone? Anurag?
Yes, I mean, it's, I wouldn't specify this to AI alone.
Sure.
It's true for any technology.
Mm.
How do you put technology to good use, and how do you avoid it falling into the hands of bad actors and, using it for nefarious purposes? One obvious mechanism is regulations, and putting them in place. I think the challenge is that with most of AI and similar technologies becoming democratized and having open source access, regulations beyond a point, and sorry to use the word, end up becoming meaningless. So the question is, how do you govern technologies in a situation where traditional governance mechanisms do not exist? Yeah. Um, and I think there it comes down to a few non-traditional ways, right? I think one is linking these to financial incentives. Uh, you know, I would take an example of Bitcoin, yeah, but it's a very lateral example. But uh, you know, it works in some places, doesn't work in some places because there's a financial incentive linked to it. So can you link the right financial incentives to this? Yeah, that's one. I think the second is where regulation can still play a role, but not direct governance, is incentivizing the right behaviors, because you cannot be the police here, but you can be the, the, the agency which hangs the carrot for the right behavior. Yeah. Which means that, look, you deploy AI for something which is meaningful and good to the society, then there is some fruit of monetization, valuation, broader scale up, rollout. Versus if you use it for nefarious purposes, then we will shut you down, right? I mean, China shut down Bitcoin exchanges for some reason, right? So I think that's how it has to be perhaps played out. It's not a straightforward task. It's perhaps one of the most difficult things to do in this new technological paradigm that is evolving in this world. Yeah.
Thank you for being very realistic, but I like your answer. Let's hear from everybody. Helmi, Rose, Lakshmi. We have bad actors out there. That's real.
We do have bad actors out there. I think even before we venture that, it's basically the skill set that we have nationally, or at least in terms of governance, whether people or regulator will be equipped enough to even know that this certain AI modeling is biased, is biased to a certain demography, or maybe it totally lack consideration of other demography, and the likelihood to profile people and penalize people just due to I want to say, like, I don't think it's nefarious sometimes, but dealing with AI, I think sometimes the issue is the fact that how the model is being developed and what are the data sets that will be made available. So I think in this case, definitely I would agree from Anurag saying that incentivization definitely work well. We do need regulation there, but I think incentivization work well as well, especially when you speaking from personal experience, right? When you deploy an AI that doesn't necessarily tie to product or commercialization or marketing and in public health, it was initially really hard to get any support or even back for the project. So we were quite appreciative, like when entities like Microsoft actually helped us with sponsoring some of their technology, Azure, and also even the Ministry of Science in Malaysia, they incentivize us in providing us grants, and that actually help us to deploy our dengue predictive solution, across another country, another states. Because otherwise, if I can't make money out of predicting dengue, the next one I would say, like, predicting sales of some other item, right? So I do have a point there.
Others, Rose, Lakshmi?
So for me, I think handling that usually starts with the will. The will usually that comes from the regulators. If there is this will by governments to be able to, there is this digital solution which can be able to solve such and such a problem, then we have a good starting point. But then to the digital innovators, for example, some of these algorithms or some of these models that are being developed, especially when you take a model to a medical field, the person who doesn't know the black box that happens around these models, then there should be a will of the developers or the innovators to be able to bring all the necessary stakeholders on table and explain what we call, like, for example, in artificial intelligence, we call it explainable AI, be able to explain the model and be able to explain to people in the easiest language that can be able to understand about the solution that is being developed, so that they can be able to perceive it with a positive mind. So once we have that, we have the will, we have models being understandable by the medical personnel who are going to be able to deploy them, then there is going to be a ground where issues of the will of bringing participants to be able to give in their data sets, to have government being able to authorize the use of the different data sets and to be able to allow participation from the different participants that you want to engage in a given study, then that will become very easy, and at the end of the day we shall achieve the end goal, which is bringing digital technology assisting public health.
Thank you.
Then the other thing is about reducing also the biases in the data sets that we collect, so that when you reduce biases, for example, you reduce biases that are against women, that are against children, these kinds of models will be very well perceived in the end.
Yes, sometimes growth is called political will, and it must be institutionalized. Anything from Lakshmi? I have one last question. You can make it quick. One simple question.
I think everyone has spoken very eloquently about this, so I don't have a lot to add, but I'll just say I really appreciate the question. I think oftentimes we jump into the technology itself because of the catalytic impact that it can have. And so it is important for everyone that's involved in this process, whether it's government from a regulatory perspective, or whether it's us as people who provide input or implement these technologies, to step back and think about the implications it can have without getting too excited about the value that tech can add here. So just appreciate the question.
Thank you. We have exactly 2 minutes left. So I want to ask every panel member to give one government policy or strategy decision that you think is topmost in your mind. If you had the opportunity, what is the one thing you would like governments to do? Anurag.
I would borrow from Dr. Helmi here and his point. but invest more in upstream. Invest in population health so that you don't fill up the tertiary care hospitals.
Thank you. Helmi?
Well, and I like to differ from my point. I think one of the thing that the government can readily do now is basically to adopt two things. Number one is basically the AI maturity framework. So they should benchmark themselves against other country, and I think this will create drive, at least a policy drive, to move towards AI adoption, like Singapore, for example. And second one is kickstart back the open data initiative. It was something that we had previously. I believe it was under Academic Science Malaysia, but I think it was not. Yeah. So I think with open data, definitely there will be a lot more to be
Thank
done.
you. Yes, we are pushing it. Rose, your turn.
From my end, I don't know how it is from Malaysia, but the one policy is adoption of digital technologies in public health. So that there is a move, there is a will by our governments to be able to, appreciate the kind of capabilities that digital technologies can play in the field of public health.
Okay. Priorities, huh? Okay. Lakshmi, you have the last word.
10 seconds. I would say investing in digital health capacity. So having the skills and experts within government as well as within the healthcare profession.
People, systems, organization structures. All right. Thank you very much. Wonderful. So I have to thank all panel members and of course all participants. There is one offer from Mr. Simeon Meaning coming from Moi University, Kenya College of Health Sciences. He wants to have partnerships with all of you. So you're welcome. So with that, I thank you again, and it was a wonderful opportunity to hear and to learn from all of you. Thank you again. Bye.
Thank you so much.